He's a senior emergency specialist at King's College Hospital, London, Dubai. He's an award-winning emergency physician, an educator, an innovator with leadership in AI-driven urgent care and global medical associations. Ladies and gentlemen, help me welcome Dr. Hakkim Ibrahim. Makofi kwake tafadhali.
Yeah.
So how will I operate this?
Yes.
How will I operate the slides?
Oh.
Good evening, everyone. First of all, thank you so much for wonderfully organizing this health summit. To the organizer, I am Dr. Hakkim Ibrahim Muhammad Ali. I'm going to talk about a concept of building a new era of emergency care in Tanzania with my expertise. Next slide. Before we go, let me just introduce myself. I'm an emergency specialist, currently working in King's College London, Dubai Hospital. I'm working in Gulf country for the past 15 years. Started my career in Mkata Institute of Medical Science, which is a 1,500-bedded hospital in India. I did my master's there. And then I moved to Qatar, the Hamad Medical Corporation, or the busiest emergency department. And from there, like after 4 years, I worked in Abu Dhabi, NMC Royal. It's one of the largest private hospital with an emergency system. Moving forward, right now in King's College London Hospital. And I would be proud to say that I have a very good association with St. Joseph University and being a visiting faculty. And thanks for Dr. Anand, the Director of Operations, for bringing me here for this talk. And being associated with St. Joseph University, we have a doctors forum in which we have like 170 doctors who are in touch with the university. We've been coming to the university for lectures for the medical students. Thank you so much, sir. So next slide. Before we begin, let's watch this video to know about this concept and visualize this better. Can you play the video? Volume, please.
Called the Riyadh Season Cup.
Can you start from the beginning if you don't mind?
Out of reach that matters most.
Volume, please.
In Tanzania, every minute can mean the difference.
In Tanzania, emergencies can strike at any moment, and every minute truly counts. Yet for too many families, help is out of reach that matters most. The reality is stark and urgent, affecting communities across the country. Unlike many other nations, Tanzania does not have a single unified emergency number. This means that in a crisis, People often waste precious time searching for the right contact instead of getting immediate help.
For the first time, Tanzania will have one clear emergency number to call in moments of crisis. A central dispatch system connects callers directly to help, guiding ambulances to patients quickly. Advanced life support and basic life support ambulances reach urban and rural areas, staffed with trained paramedics performing vital treatments like CPR and oxygen administration. On-scene triage prioritizes patients based on urgency, while drones deliver essential medical supplies to remote locations faster than ever.
Thank you for watching. Next slide. Next. Next. Yeah. Coming to the reality in Dar es Salaam, Tanzania is currently facing a critical challenge with one of the highest road traffic deaths in sub-Saharan Africa, which is almost 16 deaths per 100,000 people, and many of these fatalities and disabilities could be prevented with timely emergency care. Next slide. So Tanzanite hour. So this is nothing but a golden hour in an emergency medicine. Anybody who's here with an emergency doctor will accept with me. The first 1 hour is the most critical hour for any patient who's present into emergency department with any fatality. So the first 1 hour we call as golden hour, and that's the most important thing, like the survival rate improves. Next slide. So the concept of Tanzanite hour, inspired by the golden hour principle in trauma care, represents the critical first hour after a medical emergency where timely interventions save life. Tanzanite is unique to Tanzania, making it a national-owned healthcare identity. That's the name comes from. Next slide. So the fast medical intervention saves life. It also increases the survival rates, reduces complications, manages blood loss, improves long-term outcomes, and of course prevents secondary injuries. And that's the reason we brought this concept from that. Next slide. So this is an article recently published by the WHO. So there is a critical gaps in emergency response system as such, and there's a lack of structured coordination, absence of formal emergency medical service, no centralized dispatch system. There are ambulance system, ambulance network by a private and everything, but there's no centralized dispatch system available, which is a gap. A serious shortage of ambulances. Number of ambulances are there, but that's not enough. Additionally, there are limited first aid training program, which again, it adds, hinder the effective of emergency care and exacerbating the problem. Next. So the most important thing in emergency system is a pre-hospital care, and the emergency treatment starts from there. So that's the first gap has to be filled up, the pre-hospital care, for which we identify there are some current challenges in pre-hospital care. So the transport delays, which is main because of limited ambulance and poor road access, and the rural access gaps, like many communities depends on the motorcycling, their own private vehicle rather than using an ambulance, and lack of trained responders. So there are like some good Samaritans, like they are helping the people, but they are not trained well. So it is very important to train people, train paramedics to give a pre-hospital care. And hospital overload. The major hospitals like the Mohammed National Hospital faces overcrowding and triage bottleneck because the pre-hospital and the peripheral networks are not functioning well, not adequate enough. So the key factor to establish here is bring an emergency number which is free to call for any citizen in Tanzania, which will be the number one to establish. So there will be like no confusion. In case of any emergency, there will be one number to call, and that should be like taught to all the people in Tanzania. And bringing a centralized dispatch system, so that will help to network to coordinate with the pre-hospital care and the hospital care between the rural hospital, national hospitals and regional hospitals. So there will be a one centralized dispatch system. It's like an eagle eye watching all the entire emergency system. That fills the gap. And providing an ACLS and BLS ambulance, which will come in the next slides, you will see more. So equipping the ambulance with appropriate equipments, like based on ACLS and BLS. And trained paramedics and on-scene treatment, which is upcoming now in all the developed countries. The paramedics are being trained, the GPs are trained, and for emergency care and pre-hospital care, and most of the treatment they're trying to establish on the scene so that we achieve the Tanzanite hour. And coming next to the most important thing, the satellite urgent care hubs. You can call it as, I call it as urgent care because I can proudly say that I brought the concept. I'm going to establish in UAE very shortly. And this is something like, is going to help and change the game. So you can call this as a satellite urgent care or maybe an emergency center or a trauma center or acute ambulatory care, or whatever you call. So that's going to fill the gap between the rural and the national hospitals. And triaging a patient in pre-hospital and in-hospital, that's also an important thing. And integrating with the telemedicine, teleradiology, which is again a key factor. A drone assist for a blood supply, blood product supply, medical supply, antivenom, that's going to be a vital role. And especially it's bring down the manpower as well. So let's see one by one. The next slide. So before we go, let me just bring out some successful model and with the similar projects going on. So this is like 108, it's a number for a free-to-call telephone number in emergency service in India, which is currently operating in 35 states and in union territories. This is under the public and private partnership with funding from the National Health Mission of Ministry of Health and Family Welfare and Government of India. Next slide. Just a bit of details about it. As of 2024, there were 10,993 ambulances in service. The ambulances are classified into a basic life support, a non-emergency ambulance, and advanced life support ambulances. And in 2019, they employed 47,000 people, attending at 27,000 emergencies per day. That's a huge number. And this is what Tanzania should look for as well. And because once we start the system, we are going to see huge numbers. The average response time was 14 minutes in cities and 31 minutes in rural area, which is something really vital. And that's the Tanzanite hour we're trying to achieve within 1 hour. So within 1 hour, we try to achieve the response, and it improves the mortality. And it's in this model in Neonatal in India, it improves in fact, decreases the neonatal mortality. And that's one of the important things achieved by the Neonatal. Next slide. So again, when you put so much of ambulance and infrastructure into place, definitely the cost just matters. But you see like an interesting thing, in 108 ambulance in India, the infrastructure costs less than a $0.5 per person served compared to the US $50 for a similar 911 service in US. And per person service costs range up to $1.15 in India compared to the $800 in US. So likewise, if you strategize things and put it in the right place, this can be achieved. Next slide. So coming to the UAE ambulance service, which is called DCAS in Dubai, where I'm working currently, this is a strong model according to me, and they have a centralized dispatch system, and they are functioning Emirates-wise. For example, Dubai, they have a DCAS system. Abu Dhabi, they have a 999 system, which is operated separately. But they have a centralized dispatch system that is very important. And this is like a public funded, and all the insurance company covers the emergency transport thing. Elective transport, of course, they'll get a bill. So the beauty of this, keeping a centralized system during a recent disaster in COVID, like it was working beautifully. The reason is the government has taken over the emergency system, and in fact, the hospital beds during the time of COVID, and everyone knows that it's a crisis for the bed. So it was because being centrally operated, it was very well organized, and the government knows like where is the bed availability and where we can put the right patients, because there are all patients sick, out of which like who deserve the bed, which is being operated by government, so which avoid the confusion. So that's an important thing. During a disaster period, this will be definitely helpful. Next slide. As I said, the central dispatch system is a key to operate the entire emergency system. Next slide. So this is about an ACLS and BLS ambulance. BLS ambulance, like we can do a CPR, basic airway management, oxygen administration and patient transport. And ACLS ambulance, it's again like we need to equip with advanced equipments to handle advanced airway management, defibrillation, intravenous therapy, cardiac monitoring and medication administration. So based on the availability, based on the area where we are going to place, and rural area or regional or national, so this ambulance can be placed accordingly. Next slide. So when we update system, sometimes you will see this as well. So patients sometimes when we transport, they want to update, they will take a selfie and update in the Facebook. So this also happens, we need to be ready. Next slide. So how are we going to achieve life-saving protocols and community training? So that is most important. This is what we are trying to do. Like we are associating with St. John's and we are trying to put up a emergency curriculum and paramedic course and everything's being taught. So train the first responders, drivers, teachers, leaders, and basic life support should be mandatory for all the healthcare workers. And training them with CPR and AED use. Can anyone tell that where is an AED machine available in this hall or in this building? The organizer, please. The automated external defibrillator, which is a life-saving machine for anyone who has got a cardiac arrhythmia or cardiac arrest. The first thing which we need to bring is AED machine. So I recommend and advise, we need to know first of all where is this AED mission, and we need to have that. This is a basic thing for any country, for any hospital care, or any healthcare workers should know about this mission. So we need to teach them. The first aid for bleeding, burns, fractures and bites, this will help for the rural areas as well. Establishing a national bystander first aid program. A public awareness campaigns on Tanzanite hour as we are recommending as a national identity. Next slide. So being an emergency physician, we do a lot of work. So we have an advantage also. So we only run for anything. So people think that we are running for an emergency. But sometimes we need a break. So we used to run for food as well. So next slide. So how to make it more stronger and quality based, because when we establish an emergency system, we have established an ambulance now, so how to categorize the patient, that's how there comes a triaging system. So this is a process of sorting and prioritizing the patient based on the severity. There will be a trained nurse or paramedic who can do this using the clinical signs and symptoms to assign the triage level. So based on the triage level, we give the priority to the sick ones rather than first come, first basis. So, next slide. And this is the level of triage. Level 1 comes to the immediate life-threatening and level 5 will be non-urgent. Next slide. So American Academy of Emergency Medicine, and so they're recommending AI in ED triage because that's a lot of volume we are going to see in emergency department. So as per their research, they are recommending that AI, artificial intelligence based ED triaging helps improving the performance. And a thoughtful integration of such AI system could lead to improve in triage clinical ability to prioritize ED patients. This is also established in Johns Hopkins and after research. Next slide. So when you do a triage, you will see this as well. So a patient having a bracelet, because we're going to see the vitals, we're going to take the clinical symptoms and history. So you'll find like a bracelet saying that I'm allergic to the man. So possibly we need to train a lot of females as well. So coming to the next tool, like the key factor, drone, this is going to be definitely a game changer because it cut down the manpower as well. So let's talk about the drone. And I found a surprising thing, since 2016, Rwanda has partnered as Zipline with a California-based drone deliveries company to transform how the medical supplies are distributed across the country. And drones have a wide range of potential use and can support traditional logistics system, taking advantage of their speed and versatility. And this definitely helps in emergency situation, like any remote places or a rural places or a tourist hub. If anyone cannot access, the drone can access and it can deliver the AED mission. Now, for example, we don't have an AED mission here. So when we have a drone assist, and it can bring the AED where we are and where there's an emergency. So that's the beauty of this. And thoughtful investment and right policy definitely is going to be a good thing for the emergency system. So now come the main factor, the urgent medical clinics or a hub. And I would probably say that's Hakkim's model of urgent care center. And this is going to be the first of its own kind, a standalone urgent care I'm trying to establish in Dubai. But the beauty of this, it can be customized as per the need. If you want to put it in a rural area, it can just function as an ambulance center. Or if you want to do it in a regional, it can be function as an urgent care. If you want to upgrade more, it can be functioning as an acute ambulatory care. This is nothing but a polyclinic. We are attaching in emergency beds and operated by an emergency physician. That's the concept. We can discuss in detail if anyone needs. You can contact me. So putting these hubs in wherever the place, for example, like I would suggest we can actually transform the health centers into this urgent care so that they can see the primary cases, plus they can treat the emergency acute cares and everything by a trained emergency physician. So what will happen? We can see the next slide. Next. So basically satellite urgent hubs, what they do, they reduce the tertiary burden, and it also bridges until the referral. It bridges from the rural or like a tourist corridor to a national hospital. It can be a bridge. And this is basically a small strategically placed medical facility designed to provide a timely emergency and urgent care services outside the major hospitals. So that's the thing. We don't have to put a 100-bed hospital everywhere. So we can actually form a polyclinic with a trained emergency physician, and we put some like emergency beds and with an equipped with a proper like advanced things so that it can be converted as an urgent care. Next slide. So in detail, the purpose is to stabilize the patient during emergency. It could be trauma, obstetric complication, acute medical condition before transferring to the higher level care. So as I told you, the first 1 hour is very important. When these centers are available in the rural or like a regional hospital, it can save the time. And service offered could be like basic emergency resuscitation, airway, breathing, circulation, and initial trauma and obstetric care. Telemedicine can be linked with tertiary hospitals so that integrates the center. Ambulance or a drone dispatch points for a quick transfer of medicine and blood delivery. So staffing obviously needs a trained emergency nurses and trained clinical officers or a paramedic with a remote specialist support. Benefits or rapid access, it's reduces critical delays in emergency like road traffic, postpartum hemorrhage, snake bites, decongestion. It prevents overcrowding in the tertiary hospital as well. So it does both the benefit actually. And equity brings emergency care closer to the rural and hard to reach the population. The population and the rural people, emergency care and quality will be definitely improved. Next slide. So integrating urgent care centers, it's just a move beyond hospital-centric model and equipped with imaging, lab stabilization beds, and integrating more with telemedicine and teleradiology, which my friend will be talking about that. A function as a stabilization and a referral node in a national grid. Next slide. So Tanzania has got a global tourism destination like Serengeti, Kilimanjaro, and Zanzibar. So there are risks, especially mountain climbing, accidents, safari vehicle rollover, drowning, wildlife injuries. So when that happens in that remote areas and the tourist spot, and the Tanzania will be helpful to establish. So the remote sites are hours away from the tertiary center, risking the loss of Tanzanite hour. So dedicated tourist emergency response network could boost medical tourism confidence. Next. So how to establish like telemedicine, connect the remote urgent care to a city specialist, and a teleradiology immediately reporting via cloud platform, and a GPS ambulance tracking for a real-time coordination. So the ambulance can be coordinated with the GPS, which could be a good system. And as we talked about before, drones, it can deliver AED, blood, antivenom and first aid kits. So the private sector synergy with telecom, hospital and insurance companies as well. Next. So just like a model roadmap, what we can do, phase 1 in 0 to 2 years, we can pilot urgent care hubs in Salaam plus Kilimanjaro, a digital centralization command center for ambulance and telemedicine, a national-wide BLS and CPR training, which could be done in the phase 1, and phase 2, 2 to 5 years, expand hub to highways, tourist zones, and integrate teleradiology and AI triage. And on phase 3, we can establish a national emergency grid linking all facilities and position Tanzania as an East Africa's emergency innovation leader. Next slide. So investing in emergency medical care saves life, strengthens communities, supports economic growth, and builds a more resilient and healthier society. Next slide. So thank you all. Let me introduce my friend Dr. Shivakumar Dhanaraj, who's a neurologist. He's a consultant in one of the large government hospitals in Dubai. So he'll be talking about teleradiology and telemedicine. Thank you.
Hello everybody, good evening. It's a long day. I think you are all tired, but let me make it short and sweet. First of all, I would like to thank Anand sir for giving the opportunity through St. Joseph's University. We are attached to St. Joseph's University for teaching purpose, as Dr. Hakkim told, and we're grateful to Father Arul Raj as well. And I am residing in Dubai for the past 16 years. I'm working in Sheikh Khalifa Specialty Hospital as a consultant neuroradiologist, and I am founder of a scan center in Dubai called Al Safa Radiology Center, and I also do AA project called SonoSift, which is registered in US. So and also a member of Commonwealth Medical Association in the AA division. Next slide. So what is telehealth in emergency care? So basically, the definition is that it's a digital communication technologies to deliver urgent care in a remote place. So it is how it can be done. It's a real-time consultation can be done, or it can do triaging, it can do diagnosis, it can do monitoring as well as follow-up. So this gives a very good, very helpful for patients who come for acute emergency care. And the scope is either it can be done as a synchronous, that is real-time video advice of the doctor to the patient, or it can be from a asynchronous mode.
Sorry, please summarize. You have 2 minutes to make.
No, I just started. Okay. I mean, my partner to call the time. Okay. Next slide, please. So, tele-triage is the main thing where we can avoid many patients directly going to the emergency department, because we screen remotely that which patient needs emergency care. Then tele-emergency medicine, as I said, it's a tele-consultation. Then virtual rounds is the doctors can avoid infectious disease by remotely advising the treatment for the patient. The next slide. So this is a study in Tunisia which shows that how the telehealth has reduced the emergency follow-up visits, and everything can be done remotely. In Tanzania, telehealth can extend the specialist access to remote areas where it is not possible to see the specialist, and it forms a mobile health platforms can help in support triaging and follow-up. So here we can here there is partnership with NGOs like AMREF and PATH, which helps to sustain this model. Next slide, please. This is a slide for dedicated to my friend. Emergency physician. Next slide. So regarding mobile health, these are the things which is available. For lack of time, I'm just rushing it. Next slide. So what are the Tanzania specific examples? Actually, when I was about to start this lecture, I was wondering the Tanzania healthcare, this much development is there, I was not aware, truly speaking. Then I saw there was mobile hotline, there is a Daktari smart application for telemedicine, there is M-Track where the ComCare, these are the community workers as well as patients can have the mobile data where the health data is being tracked. And next slide please. Being a radiologist, we like sharing a lot of pictures, seeing pictures and then sharing it. Next slide please. So this is how we have to always see in all the angles being a radiologist. Next slide. Next slide. So regarding teleradiology, it is transmission of radiological images like ultrasound, CT, MRI for remote interpretation. So this helps where there is in that area where the radiologist is lacking, and it helps very much nowadays in emergency care as well. Next slide. So infrastructure requirement, you need reliable internet and satellite connectivity and digital imaging equipments, PACS system, and there should be a trained technician and staff to send the images. Next slide please. There's another joke. Next slide. That was a house patrol now.
Thank you. Thank you very much. A hand of applause to him. Very prepared, a very detailed presentation, as you can see. A lot of pictures and explanations. This is to explain on how emergency medicine is very important. The first hour of life after the accident is where all the good can happen and all the worst can happen. So a hand of applause once again for the Tanzanite hour. So now, as we all know, we've been experiencing a lot of good information, but we are running out of time. So I'd like for the next presenters to really adhere to the time allocated. And the time allocated will be 10 minutes per presenter. So ladies and gentlemen, help me welcome Kofi. He's going to present about sustainable digital health. So, excuse my language, the name is Gabon. So, makofi kwangu tafadhali. I did my best. He is a country representative at Korea Tanzania, specializing in ICT, health systems, development, and AI, with interest in hospital management systems, having gained expertise in public and private sectors. Help me welcome Mr. Hansol.
Oh, thank you so much for your introducing me, but that is the country representative is here. But another person, surprise. I'm another person, I'm the health specialist in Korea Tanzania office. So I'm going to do the presentation, but I expected there is something here. I want to hide my script, but I cannot hide something. So just to look at the monitors, please, and you can sleep. But the important slides are coming maybe end of the 2/3 the slides, so you can wake up. I will let you know. So I want to introduce about the organization first. The Korea Foundation for International Healthcare is the organization, the public agency affiliated with the Ministry of the Health and Welfare in Korea, Republic of Korea. And we are working with the government, Tanzania government, especially Ministry of Health and Pure Large and the governments as well. So we are thinking about the digital health in Tanzania and working with Tanzania, what we can do. So I will do please. Digital health is the field of technology and services that integrate ITC into healthcare to support personalized health management, disease prevention, and treatment. It makes us cutting-edge technologies such as the big data, IoT, mobile health, and acts. The key feature is the ability to measure, diagnose, and monitor health status without the constraints of the time and places while providing personalized medical services. Sorry, maybe the slide has been changed, so this is previous one. Can you find the new one? I'm very sorry. Sorry, I will keep the 10 minutes. So just listen. Thank you. So since the new government in 2017, actually the digital health started to discuss maybe start of the 2000 years, and Korea also started to discuss about digital health. But actually we started to make the strategies from the 2017. The digital health has emerged as a core sector of the fourth industrial revolution in Korea. Thanks to deregulation and the large-scale investment, it has grown rapidly, in particular with centralized efforts and investment from the private sector, government, and academia, and industrial ecosystem is expanding. Although legal systems and infrastructure remains as challenged still now, but Korea is leading the digital healthcare industry based on one of the world's most advanced ICT infrastructures. Korea's digital health vision is to enhance national health and innovation the healthcare system through advanced digital technologies such as AI and big data. The goals of this vision are realizing people-centered health management, improving accessibilities and efficiencies of healthcare services, and building a digital health industrial ecosystem. So Korea has been able to take the next step in implementing these strategies because of its strong foundation, such as a high adoption rate of EMR and the universal health insurance system, which provide great potential for digital healthcare development. To achieve these goals, Korea's digital health policies has presented the following strategies and the directions. We are making and developing many acts, for example, Personal Information Protection Act and the Medical Services Acts. Before. And the regulatory sandbox system, so whoever who want to develop the system, we make the sandbox system and let them play in the ground. And the promotion of data utilization and the activation of data transaction. And the fast-track approval system for rapid authorization of innovation technologies. And the supporting for industry developments and commercialization. And telemedicine pilot programs. We are performing all these activities. And now I want to tell that in Tanzania context, the government of Tanzania priorities UHC and the SDGs. So policies focus on improving access to services, enhancing quality, expanding infrastructures, and strengthening health worker capacity. With regarding to digital health, Tanzania introduced a national digital health strategies from 2019 to 24 to improve a fragmented system. Its main focus areas are ensuring interoperable of health information, strengthening personal data protection, and improving quality of services. The strategies emphasize improving healthcare accesses in rural and underserved areas, supporting data-driven decision-making, and providing patient-centered services. Despite of these strong policies, but many challenges are remained. Shortage of and uneven distribution of healthcare workers, resource shortages, and outdated equipment, geographical barriers and poor infrastructures in rural area, fragmented health information system with low data quality, need for strong leadership and cooperations, low public health literature, and inadequate ICT infrastructures. So the digital health can serve as an important tool to address these challenges. KOFI, together with the Ministry of Health, the local government has developed a plan to strengthen Tanzania's health system using digital health as a tool. Areas are collaboration, including AI-based diagnosis. You need to get up, this is important. AI-based diagnostics, the support system, and reliable telemedicine solution for underserved rural area, and smart medical services, smart medical devices for clinical diseases, management and monitoring, integration system linking GOTHOMIS and Nahya EHMSs and the other systems, and regulation and security solutions for data protection and information securities. Through KOFI and Tanzania cooperation, we are the making targeting, and we are make a future too. The digital technology will address Tanzania healthcare challenges, and digital health will enhance accessibility, efficiency, decision making, and quality of care. With a strong governance and investment, digital health is a catalyst for equitable and sustainable healthcare. And Korea's ICT and digital health experiences provide a proven model, and it can support to Tanzania. And by leveraging this expertise, Tanzania can accelerate robust and sustainable digital health ecosystem development. The KOFI and Tanzania partnership is a model for mutual growth, helping Tanzania modernize the system while giving Korea valuable global health cooperation experiences. So we are now modeling the projects with the Tanzanian government. So we're hoping the digital health sector through with the supporting and cooperation, and Tanzania, the health system will be more powerful and more strengthened. So thank you so much, everybody.
Thank you very much. Yes, he really did his best to adhere to time. Without wasting time, I'd like to welcome Waja Mama, who focus on improving the well-being of communities in Zanzibar. Help me welcome Nafisa. Please welcome Nafisa na kofi na vigelegele kwake tafadhali. Thank you very much. That's very rare. You're welcome.
Thank you so much. Good afternoon, everyone. First of all, thank you so much for being here. I know that it's been a long day. My name is Nafisa Jiddawi, and I am here to represent Waja Mama, which is a Zanzibar-based organization. Wait a minute, where are my slides? A Zanzibar-based organization that is improving the well-being of communities starting at the beginning of life. So, we've all heard the numbers all day. Women and children are dying left and right. We know that in sub-Saharan Africa, women are 50 times more likely to lose their lives from pregnancy and childbirth-related complications. Their children, compared to wealthier nations, their children are 10 times more likely to die from during their first month of life. Just in Zanzibar alone last year, we lost around 1,800, we had about 1,800 perinatal deaths, and most of them are preventable. And we all heard today that a lot of these deaths can be prevented if we have high quality healthcare services and if our workforce is properly trained. Is it possible to play these, or? Yay, okay. And so, but at Waja Mama, it's not just about survival. We know that hundreds of thousands of those who do survive pregnancy and birth still live the rest of their lives with irreparable trauma and complications, including disabilities that affect their livelihoods. It also affects their quality of life. And so, next slide, please. And so at Wajamama, together with our partners, together with the Ministry of Health, we are committed to changing these narratives because we believe that women and children deserve better. And so we're a grassroots organization. We were founded in Zanzibar, and we are women-led. And we were built on the belief that initiatives aimed at making the greatest social change must begin by focusing at the beginning of life, because research has shown that when children have a healthy start to life, so like during the first 1,000 days from conception, they are more likely to be well, they're more likely to have better livelihoods, and so that means that a lot of our children, when they're suffering from all these like unnecessary complications early on, that means we're doing them an injustice, not just now, but later as well. And so we are here, we exist to transform maternal and child health outcomes in sub-Saharan Africa. We are studying in Zanzibar, and we're doing this by equipping nurse midwives. So we are obsessed with the midwifery model of practice. And so we're doing this by training nurse midwives and equipping them with knowledge, tools, and skills to provide safe, respectful, and evidence-based care and comprehensive care to women every single time. Next slide, please. So our solutions are extremely women-centered. That means that we have a big vision of a world where every woman is the healthiest version of herself, physically, socially, and mentally. Because we believe that when this happens, then babies, African babies, will have a healthier beginnings. And so that's the world that we're working towards. As I mentioned before, we are working towards this world through healthcare workforce development. We use simulation-based learning at the pre-service level as well as the in-service level in collaboration with institutions that are known for academic excellence, like Georgetown University and the University of Global Health Equity, as well as the State University of Zanzibar. We work with the Ministry of Health to do this as well. And then what we're really, really, really proud of is our group care model that we pioneered in Zanzibar. This is an evidence-based model that was founded in the US, but we've introduced it 3 years ago. And during that time, we've been refining it and testing it, and we've been delivering it at public facilities. But right now, we're at a point where we want to test out, okay, can nurse midwives employed by the government also deliver this model? Next slide, please. So with this group care model, essentially, instead of the traditional one-on-one, consultations where clinicians might have maybe 3 minutes per patient, because guess what? They have 40 other patients waiting for them, and during the 3 minutes, they have to keep repeating the same information each time. Instead of doing that, which is really not nice for the patients, it's also really not nice for the clinician, it's exhausting. Instead, we group women of similar gestational ages, and they get to go through their whole entire pregnancy journey together. And in our communities, we love to be together. We love gatherings. We love seeing our friends. And in this case, you not only get to see your friends, but they're also pregnant at the same time as you. And so you get to learn from each other. You get to connect. You get to compete, regarding whose hemoglobin is higher this time. You get to build bidirectional partnerships with your clinician. And so where you learn from the clinician, but also the clinician learns from you. Because let's face it, as clinicians, there are so many myths out there. And so we get to clarify myths in these sessions and so on. And so women they also get to, get mental health support. Because what we found is that in our participants, among the participants screened, we saw that 52% did test positive for perinatal depression, and so we're addressing that. But through all of this, the clinicians that we do equip to deliver this group care model not only learn about how to deliver group care model, but they also learn how to be better clinicians. Next slide, please. So far with this model, we have served about 1,000 women at 7 public reproductive and child health clinics in Zanzibar. This is 1,000 women that we've walked through pregnancy together. And through the services that we through our initiatives, we've trained about 150 nurse midwives. This is not just on the group care model, but other initiatives, for example, simulation-based learning, the foundations of simulation, reproductive health initiatives, how to do cervical cancer screening, and so on. So capacity building is a really big part of what we do. We also established, together with our partners, Laredo Global Health and also Ariadne Labs, we established Zanzibar's first high-fidelity simulation lab, simulation center at the State University, where now approximately 1,500 students in Zanzibar have access to this simulation lab. Prior to this lab, nurse midwives would read in their books, and then they'll go practice their skills on real humans in hospital under no supervision, because let's face it, a lot of our hospitals are stretched, and our clinicians don't have the bandwidth to mentor people and supervise. So you can just imagine how much harm was caused. But now, these healthcare students get to practice their skills and refine them in simulation settings before going out into the field. So we did that. We have also served about 6,000 women and girls through our disease prevention and health promotion campaigns. On our social media platforms, we have served hundreds of thousands of people with information about health and well-being. Next slide, please. So in terms of our achievements, as I mentioned before, we have built the capacity of healthcare providers. One of the things that we did recently that we're really, really proud of is that we trained about 35 healthcare providers on psychological first aid, because in our communities, trauma is so real, it's extremely common, particularly when it comes to just being a woman, but also like pregnancy and childbirth related trauma. And so now 35 people, including 7 healthcare providers who work for the Ministry of Health, got this training, and we're hoping to do a lot more. But also through this group care model, we've seen a 100% decrease in severe maternal anemia among our participants. What does that mean? It means that maternal anemia can actually can increase the chances of postpartum hemorrhage, which is when a woman bleeds too much after giving birth, and which is the #1 killer of women when it comes to maternal health complications. Maternal anemia can cause intrauterine growth restriction, it can cause preterm births, and the list goes on and on and on. And so when you fix that one thing, then you're really saving a lot of lives. The other thing is that a lot of our women, they come to their prenatal checkups, all of the 8 prenatal checkups, 90% of them. We've seen that mamas who go through the group care model at 100%, we have a 100% exclusively breastfeeding rates at 6 months versus 41% in Zanzibar, and a lot of other successes. You can go to the next slide. We can skip that story. Whatever. So there was a story about this woman who went through the group care model, but we'll skip that. We can go to the next one after that. So where we are right now, as I mentioned, we as Wajamama, we've implemented this model for the past 3 years. So now what we're trying to do is refine it, right? We have been refining it, but now our hypothesis is that this model doesn't have to be delivered by Wajamama, and that nurse midwives employed by the government can deliver this model. And so right now what we're gonna be doing is training nurse midwives who are employed by the government to deliver the model, and then we will continue to refine it. In Zanzibar, we're gonna try it out in other contexts as well. We're going to use data to keep refining and learning and so on, so that this model can then be used, can be the standard of care, not only throughout Zanzibar, but also sub-Saharan Africa. Next, last one, I promise. Next one, we can skip this one. So, I hope that you guys were inspired by this presentation. We have a big, audacious goal of training about 500 nurse midwives in the next 3 years, so that we can reach 50% of women and babies throughout their pregnancy journeys. We cannot do this alone. And so if you have anything to offer, for example, like if you're an M&E expert, if you're a cost effectiveness expert, you're a health economist, you know funders who can support this work, please connect with us. Next slide, please. So that we can support a lot of mamas in our communities, because through this capacity building, through such innovative models that clinicians love, that women love, that the government love, we can really change the future of places like Zanzibar.
Thank you very much. A hand of applause to Wajamama, please. Actually, I'm loving this race of time. So, to the next presenter, briefing for baby study, Nahya Salim. Karibu sana. Makofi kwake tafadhali.
Thank you so much. Good evening, everyone. My name is Shaban Usega. I'm overall coordinator for the Breathing for Babies project, and I'm here to represent Prof. Nahya Salim, who is a principal investigator of our study. So, my presentation is a lot of graphs, but I'll try my level best to explain more so as you can understand how important our study is. So, Breathing for Babies study is an implementation study that aims to enhance survival and improving quality of care for premature newborns with respiratory distress and low birth weight, those who are vulnerable to face respiratory complications. And since it's an implementation study, we have three main stages. The first one is exploration phase, which include baseline assessment. The second one is implementation phase that involve execution and monitoring. And the third one is evaluation and sustenance. So today I will represent more on the baseline assessment, which we conducted between June to August. So, as I said, the main purpose of baseline assessment is to identify the readiness for implementation of Breathing for Babies study in selected facilities within 3 use cases, which including maternal use case, neonatal use case, as well as ambulatory use cases. But also, another purpose is to identify enablers and barriers for implementation of BFB package ecosystem. So you may ask, what is BFB package ecosystem? BFB package ecosystem is a package that involves value CPAP and its consumable oxygen sources and supplies, as well as trained human resources. So some of you may not know what is value CPAP. When I'm talking about value CPAP, this is type of CPAP device which is portable, low cost, as well as non-invasive, that can be used without the need of electricity, and has been designed specifically in areas with limited resources. And it's very unique from other kind of CPAP because this one is very suitable even during transportation of babies. So in our study we have 6 facilities, which including 3 regional referral hospitals and 3 district hospitals. We are using a hub and spoke model. So in referral hospital we have Amana, Temeke and Mwananyamala, and in district facilities we have Mwabepade, Kivenule and Yombo. Next slide please. So in our baseline assessment, we use a descriptive constructional study design, and also we use assessment based on health system building blocks framework, and by using 83 indicators across 3 use cases. And in analysis, we use binary scoring for assessment of infrastructure and equipment, but also we use Likert scale scoring for competence of staffs, and also we use percentage calculation of capability achievement to calculate percentage readiness in all facilities across 3 use cases. As you see in our diagram, you can see there distribution of indicators. Next slide, please. And the overall performance of our baseline assessment. So you can see here, for example, the highest performing use case is neonatal use case with 61%, which is followed by maternal use case with 51%, and the least performing use case in our baseline assessment was ambulatory use case, which is about 45%. And the overall readiness is around 54%, which provided feasibility for us to conduct our Breathing for Babies project. Next slide, please. So, in Breathing for Babies study, we are focusing on the whole newborn journey from during the mother gave birth in labor or operating theater to transportation from labor to neonatal unit, as well as even if the baby is referred to another facility as well. So we have investigated the whole journey and identified each and every gaps. And this is very important. For example, to put it in a perspective, is like that, for example, if In a neonatal unit, for example, there is a healthcare provider who has some sort of infection and did not wash his hand properly. And in a neonatal unit, if we touch at least 4 to 5 babies, that one infection may kill up to 10 babies in that facility. In another scenario, for example, if a baby is born premature with respiratory distress, it is supposed to be on CPAP. If you delay, for example, for 5, maybe 10, 15 minutes, because in labor there is no CPAP to provide to that baby, those 10 minutes or 15 minutes are very enough to destabilize that baby and sometimes may cause death to that baby. The same even in ambulance, for example. If you are transferring a newborn baby, maybe it's premature, and it's very hot, there is high temperature within ambulance. That is very enough to destabilize that baby and may cause death to that baby. And that is not only a baby, that sometimes it may be a hope to the parents, and sometimes maybe a brother or a sister to other children. So it's very important in this journey to make sure each and everything is being done according to standard. If a baby needs CPAP after delivery, should be given CPAP. That's why we are cutting across the whole newborn journey. Next slide, please. So, for example, here in our assessment, as you see, there is this heat map show performance of use case across different facilities, where that green represents good performance, orange represents moderate performance, and red represents poor performance. So you can see some facilities are very well performing in terms of respiratory care. For example, Temeke and Yaman as well. Also, there are still some gaps in other facilities that we are trying to understand and eventually to address them. Next slide, please. So in critical gaps that we observed during our baseline assessment, you can see here, for example, in maternal use case. In maternal use case, in most of maternal labor areas that we assessed during our baseline assessment, very few of them have CPAP, for example. So it means all the children that are born in those labor, there is delay in provision of CPAP when they need them. Also, there is insufficient resuscitation kit as well as training gaps among those staff who are working on those wards. So this is very important. Also, in neonatal use case, for example, there is also a shortage of CPAP, for example. Some facilities have 2, 3 CPAPs. In other facilities, they may have 20 CPAP, but 50% of them are non-functional. So this is a gap. Also, there is inefficient oxygen supply. For example, if you go in our neonatal unit in this regional referral hospital, you will find there is a lot of oxygen tanks, and those oxygen tanks are very big. Every baby cot has its own oxygen tank, which is very risky. Some may fall and may cause damage to those babies, this is not normal. So this all need to be addressed. As well as there is training gap as well. Some healthcare provider, they don't know how to operate CPAP in those facilities, so it's still a gap. And most of the time, a good training should be like high frequency low dose, not those training like a lot of training are being done in 1 week and then the next 10 will be next year. So training should be high frequency and low dose, which is still a gap in our facility. Also in ambulatory use case, as we see, there are also the same challenge, CPAP device, monitoring device. Most of our ambulances are not equipped to monitor newborn baby during transfer. There is no even a temperature regulation sometimes, which may damage the stability of that baby during transfer. Next slide, please. So implementation recommendation, including equipment to make sure all necessary equipment are there in our facility, CPAP usage training, sustainable transportation protocol, and others. And long-term, including financing, mentorship program, and local maintenance. A lot of CPAP are not working because people are not trained how to manage. Some people, they boil CPAP, via CPAP as a disinfection, which is not required because they are very delicate. As a result, they are not working properly. You put a CPAP on a baby and it's not functioning properly. What do you expect? There will be no improvement in that baby. Last slide, please, sorry. Yeah, so by concluding that, the key recommendation we have at least there is a readiness, but there are some issues to address, and we have already started addressing them. We provided safe neonatal transfer training at MOHAS, where we trained around 200 healthcare providers. We have already also procured different kind of items, including CPAP devices, pulse oximeter of around 150 million.
Thank you very much. More hand claps to him. And we're going to the next presenter, harnessing artificial intelligence and digital innovations. Help me welcome Dr. Zacharia Mtema. Makofi kwake tafadhali.
Good evening, everyone. I congratulate all the previous presenters. My name is Prof. I'm a project manager at KEYNOTE. I manage a project called Syria and Elvira, which is for adolescents' well-being, and another one is for cervical cancer. So without wasting time, where we are from, who we are, KEYNOTE, we are three things. We are research, innovation, and technology. We are a social enterprise company that is found here in Dar es Salaam. We are found there at Mkata. We deal with different social and research innovations here in Tanzania, in healthcare, and also in the business aspect of things. But today we'll be covering our progress in the public health aspect, especially in Tanzania and abroad, maybe in other countries in Africa where we have implemented our solutions. So the supporters and collaborators who have been in Tanzania, including NCAs, it's to aid the process from where those nurses take images or perform via diagnostics at the remote areas, because we're supporting this in areas like, think of someone who is living at Mtema. It's very hard, and the issue came to that because a lot of times we had a lot of false positives coming because those providers from those areas could not diagnose properly cervical cancer images or cervical cancer issues. So most of the time when you go and do supervisions, you realize that a lot of them are saying they have very negative for almost a month, and then after maybe a year or two, you found that the solving is to eliminate those false positives. So it offers real-time data sharing, and currently we've integrated HPV DNA testing because the government of Tanzania is as the severe labs. And another important thing is AI image diagnostic. This is we have a lot of data collected over the years doing this. We have more than 60,000 something betas of cervical images at the moment. So we have trained a cervical image model based on African images, Tanzanian images, that can accurately diagnose if the image being seen is either via positive, negative, or suspect for cancer, with respect to other conditions like cervical polyps or cervicitis. So one last thing is the AI chatbot. This one is for quick help to those providers. So the CG system, another thing that is very important to it is that it can work offline, and the providers can later go to an area where they have internet access and send their cases and treat. So the CG system also include a module for treatment where we take the appointment date for when the client should return to be treated treated on based on the condition they are faced, and we also remind the providers that a certain client needs to be treated. So this is a very comprehensive system that is aiding cervical cancer aid here in Tanzania. Next slide, please. So the impact matrix is seen on the screen. We have currently screened about 42,000 women across the country. We have onboarded about 250 CCAP facilities. We have recorded about more than 900 via positive cases, and most of them have been treated. We have trained more than 380 CCAP providers with the severe system, and also we have reduced false positive by at least 95%. Next slide, please. So I really want to talk about this one based on time because I have other projects I have to cover. But we have, like I said, on previous series already aid in a lot of areas. This is just an image of the training being done on Syria. This one was taken in Shinyanga. No, it was in Singida. I'm somewhere there. And that's all about Syria, guys.
Thank you.
I'm pretty sure I still have 5 minutes, right?
Thank you very much. Time is up.
I have 2 minutes.
Let's be generous, and we still have 3 more presentations. So let's be generous and let every one of us have something to say. So for the rest of the presenters, let's be generous. So to the next presenter from TACAIDS, Delfinus Kivenule, you are more welcome. I believe there will be questions, and Dr. Delfinus, yes. Your timer starts now. So it's really interesting to know who is who in the healthcare and who does what. After this, we're going to have a very good time to communicate and network and see how we can integrate maybe company A to company B, initiative 1 to initiative 2, and see how we can improve healthcare. So, ladies and gentlemen, help me welcome Daktari. Makofi kwake tafadhali.
Hello. Good evening. Because of 4 minutes, I've decided just to present the 80th part, because I was supposed to present the issue of sustainability of national response. That is the government efforts to make sure that the response is sustainable. So I'm given just 4 minutes. Go down to the 80th, please. Yes. Okay, so thank you. Yeah, first, after realizing that there is a decline in financing HIV response, the government has developed a strategy known as the National Sustainability Roadmap, whereby various stakeholders were involved during the development, and the roadmap is ready. Now we are developing the Part B for operationalization of the Part A. But as part of looking for the sustainable financing of HIV, the government also have developed the AIDS Trust Fund. This is under the TACAIDS Act number 22 of 2021, and the foundation of ATF is rooted in the National AIDS Policy of 2001, which called for the creation of the trust fund to support the national response. ATF was created in response to growing recognition of the financing gap in the national HIV response as the international donor support is declining. Next, please. And the ATF is governed by the Board of Trustees appointed by the Prime Minister. The board is composed of 1 member from the Organization of People Living with HIV, 1 member from the NGOs, 2 members from the private sector, 1 member from the Ministry of Finance, responsible for finance, and another member from the Ministry responsible for the health, that is the Ministry of Health, and also 1 member from the PORAG, and another one member from the TACAIDS Commission. And TACAIDS, it acts as a secretariat to the Board of the Trustees. Next, please. The main objective of ATF is to raise domestic funds in order to, 1, to reduce the dependence of external donors on HIV response, HIV financing, and also to enhance the sustainability of HIV and AIDS services. Next, please. Source of the fund for the ATF. 1 is expect to get monies from the Parliament of the National Republic of Tanzania. That is during the budget period. There are some money which are allocated for the ATF, and also is for voluntary contribution from any person or institution. Also, another money is obtained by way of grant or loan from within the United Republic of Tanzania. And also any monies occurred from the investment financed by the fund. These resources have not been sufficient as it covered less than 10% of the financial resource required for HIV response in the country. So this year in June 2025, through the Finance Act of 2025, the Parliament of the United Republic of Tanzania has passed a sustainable source of fund called a levy, now HIV response levy. So from this financial year, the ATF has now obtained a sustainable financing source, which is called HIV response levy. Next, please. Now from this levy, we are expecting 0.20% will come from the minerals. And 500 will come from the train ticket. I think anyone who have traveled from the rest or have used SGR, in your ticket there is an additional 500. Have you seen it? So that one is for ATF. And also we are getting another fund from the motor vehicle registration. But this one depends on the capacity of the engine, the CC. So the money, the amount will vary according to the size of the engine or that car which is being imported. And another one is the exercise duty collected from alcoholic beverages, as it is indicated there. And also we are getting another source from petrol, diesel, and kerosene. It's 10 shillings per liter. And also from the winning tax and sports betting, there we are getting 12% from amount or value of the winning. Collection from the winning tax and the land-based casino, that is 13%. And also we are getting some money from the airport services charges on the passengers traveling to a destination within the country. That is 11,000 per ticket.
So to finalize.
Yeah, okay, I'm finalizing it. Next, please. So the allocation of the HIV response will be 70% will go for ATF, and another 30% will go for the Universal Health Fund. For this financial year, we are expecting to collect 277 billion will be collected from July 2025 to June 2026. From the 70% of the levy collected, about 193 billion will be for ATF, and about 84 billion will be for universal health insurance coverage. Okay.
Thank you.
Thank you.
Thank you very much. Hand claps for him, please. I see the future of sustainability. So I'd like to welcome a presenter from the Revolutionizing Healthcare Access through Tanzania's first digital health super app. Karibu sana.
Thank you. Good evening, everyone. My name is Mkata Nyoni. I'm the CEO and the founder of Tanzanite. So because of the time, I'll go a little bit faster and skip some of the slides. Yeah, so I'm coming from Tanzanite. We're a digital hub. We call it Healthcare Super App, which are making healthcare accessible using your phone. So this is our app. So we use, because like healthcare accessibility in Tanzania is being a big challenge. Most of us, we use mobile phone, but we use our mobile phone not for the issues which can help our health. So what we are trying to do, we are trying to make your data help you to make informed health decision. So from our tool, we call it Healthcare Super App, which are found both in mobile, in Android and iOS. You can have AI health assessment. We call it Amina. So with this tool, you can assess your health, and after that, it's agentic. It's not all about assessment. You do assessment and via our app. So far, we have 167 registered appointment with our clinics. You know ourselves, when you go to the hospital, even in this big hospital, you spend hours to meet with the doctor. Instant call, like now, we call it Uber for the healthcare. Right now, you go to our app, you see which doctor is available online, you can request, and if doctor is available, then you can go live. And at the same time, you can book appointment with that doctors, and not only the doctor, we call it healthcare experts. We have physiotherapists, we have psychologists, and etc. And in the end, you can buy healthcare services. For example, most of us, we are struggling with a checkup. So you can, with our application, you can do that. You can buy even some of the healthcare products, including OTC products, or even like healthcare tools, and we have just one of our partners is Nahya Pharmacy, and it can be delivered to you via Bolt Tanzania. So 24/7 you can access healthcare services and products. So this is our impact so far. We are reaching Tanzania 6.5 million users in Tanzania, and we have monthly active users more than 67,000 active users per month, and our tools, we have varieties of tools, so that we also have tools for pregnant women, and the menstrual tracker, which are accessing or saving more than 8,000 women are using our tools. So with the TransMed, in a single application, you can do varieties of tools. So we are happy with our partners, who are, some of them our client and our partner. We are very proud to be, TransMed is among very few health tech which are registered under Africa CDC. When you go to Africa CDC portal, you find it TransMed, and at the same time, we are recruiting. Last year, we worked with the USAID in the healthcare project. Go to the last, next. Go. Yes, yeah, so these are some of the products. When we are designing our tool, we didn't just sit in our room and design TransMed. We do like a co-designing with the use expertise, and we came from the COSEC, Tanzania Commission on Science and Technology. So even when we launched the first time, we were collaborated with the COSEC. So the TransMed, everybody, we made a tool where everybody can use and everybody can enjoy. And we are not just here, we also focus on the youth. We are attending a lot of conferences in youth, as you can see. Some of these images, some of them when we are pre-designing our tools, and some of them we are going outside. So it's not just a digital, we are linking offline and online. Thank you.
Thank you very much. Wow, amazing. Finally, Dr. Karima, karibu sana. 100 plus for her, please.
This marathon, yeah, it's so daunting to be the last one and to have this time pressure, but I'll do my best. Please, can I have my slides on the screens? So my name is Karima Halil, anesthesiologist and critical care doctor based at Mohas in Moi. And for me today, I'm going to talk to you about the essentials of critical care. So as a young doctor, sometimes back, when I started working, and I noticed that when I studied abroad and came back to Tanzania, I saw gap in anesthesia, and I thought I wanted to become an anesthetist. Next slide. And then as I was working, as an anesthesia specialist, I saw a lot of work you're doing in theater, in emergency, in ICUs, but that work ends up being wasted when it comes, not really wasted, but you go to the wards later in the morning, the next day, and you look for a patient that you really worked hard to save, and you find that that patient has passed away. How many of us have faced that? So many of us working clinically, we've seen that kind of cases. So I was wondering what is happening in our wards, what is missing, and what needs to change. So these 3 cases I've shown here are cases of patients who passed away. A mother who worked hard to deliver, a child who had malaria, treated for malaria, and then went to the ward and died, and etc. A motorcycle accident at Mooring, we worked so hard, we saved him, and then he died in the ward. So next slide, please. So what could be killing these patients? We know what to do. We know how to treat preeclampsia, we know how to treat malaria, we know we have our CTs, we know how to do excellent surgeries. But what really happens overnight, just press on, is that these patients could have become critical at some point. Somebody's bleeding, somebody's airway is blocked, and we don't notice, and then we end up losing this patient. Next. So this is, just continue, please. It's nice to control your own slides. Yeah, continue. So this is a problem that is global. What we see is that these people could have become critically ill. And how we define critical illness is just any state of ill health where there are our vital organs have a dysfunction with a high mortality rate if treatment is not given. The mortality rate, as you can see, is around 28%. And what these patients actually need is critical care, which is identification, monitoring, and treatment of their critical illness with the initial and sustained support of vital organs. Next slide, please. So critical ill patients every year. Next slide, please. So there's a big study that we did that was published in the Lancet this year that showed, it's called African Critical Illness Outcome Study. We were part of it, we were leading it at MOHAS. And what we found is that 1 out of 8 patients are in our settings as critically ill. And 50% of these patients are not receiving the most basic care, fluids, oxygen, being positioned in the right position when they need it. They're dying because of these very, very essential things. And most of these patients are not in ICUs or HDUs. 90% of them are in the wards. Next. As you can see, this is not only a Tanzanian problem, but a global problem. Even in other parts of the world, it is also a problem. Next. So we worked with the government of Tanzania to improve our state of our patients from this being provided care at 33% in Tanzanian facilities to 81% the last 3 to 4 months. And I just wanted to show what we did together with the government. So we did what we initiated the concept of essential emergency and critical care, which is the most basic care that all critical ill should receive. It is cost effective, it is feasible, and it can be done in any, it is one of the ECHO resolutions of the World Health Assembly, and ECC actually addresses that problem. It's very cost effective. Next. And we do a lot of consensual work, and we have a government strategic plan that was developed by the Tanzanian government, both Zanzibar and mainland, to provide this ECC to all our patients. And we have a program called ECIT that is funded by UNICEF for the government, and we at MOAS are providing technical support to this with the objective to operationalize ECC in our primary healthcare facilities. And what we've done is we've done a lot of groundwork with assessments, and we had a lot of findings of what is missing, and we started a package of work. That is the most important part of this. Next one, this is the most important thing. We did training. We knew that training is not adequate, so we did training, but we also involved the leaders of all these facilities. We had workshops with them. We provided them with tools to institute ECC in their facilities. We had focal persons. We had a lot of engagement with them through webinars, through other trainings, and we were able to reach this stage whereby we take vitals every month and see how we are performing. And we saw that before we did the assessments, or after the assessment, the care was at 33%, but now consistently where we did trainings and everything for everyone in that facility. The outcomes have been good. This is our last one. The outcomes have been good. A lot of, as I've told you, the percentages have gone up, but we have also anecdotal information from the regional leaders saying that their referrals have gone down, mortalities have gone down, and a lot of things have improved with the institution of this. And this is a global initiative. We have hubs all over the world. This is a success story of Baby Lillian, who was treated now, coming from Mariam to this one, where she was treated and she got the good care after somebody was trained and her life was saved. Thank you. So I would like to, what I would like to do is invite you to join our network. That is our global, ECCglobal.org is our organization, and that where you can join our network. You can just scan the QR code. You can become a member of the network and help us or work together with us to improve the care of your patients and improve also the well-being of the healthcare providers, because if you don't provide good care, you also get depressed. Thank you so much.
Today was quite a marathon, so this marks the end of Who is Who in Healthcare. It was an honor to be your moderator, and after this session, we're going for cheer awards, so please participate. But Don't hesitate to network, don't hesitate to follow people personally and ask them questions that you couldn't ask here. As you could see, the timetable was really, really tight, but the Who is Who was an amazing platform to know who does what in the healthcare. So you were with me, Esther Bramble. Until next time, thank you very much.